You're tuning into the O&P Check-in, an SPS podcast. I'm Brendan Erickson, a regional sales manager at SPS. This show brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community. Co-hosting with me today is SPS Sales Account Manager and Team USA para-athlete, Travis Ricks. Welcome, Travis.
Thanks, Brendan. Glad to be here.
Absolutely. Let's get started.
Knit-Right Core-Spun Gradient Compression Socks are made with core-spun yarns, which are created by twisting fibers around an inner fiber to create one yarn. This process enhances strength, durability, and stretch. The result is a sock that is easier to put on and more comfortable to wear than traditional compression socks. Order Knit-Right Core-Spun Gradient Compression Socks today by visiting spsco.com.
This year's Microprocessor promotion is packed with performance. From October to December 31st, purchase a qualifying foot, knee, elbow, or hand microprocessor product and receive a Carhartt cooler backpack. Browse the full list of microprocessors from top brands like Aether, Blatchford, Nabtesco, Proteor, Steeper USA, and more. Plus, shop and save with additional supplier partner promotions. Visit spsco.com/promotions today to learn more. Hello, listeners. Today we are chatting with Dr. Christopher Kevin Wong, a professor of rehabilitation and regenerative medicine at Columbia University. Dr. Wong also serves as associate editor of Prosthetics Orthotics International and is the founding co-editor of the Journal of Clinical Education and Physical Therapy. Welcome, Dr. Wong. We're so excited to have you on the show today.
I'm excited too. Thank you for inviting me.
Absolutely. So again, I know you're super busy as a doctor and as also an academic, so thank you for taking time out of the day today. But could you kick us off by sharing a little bit about yourself and how you became involved in rehabilitation?
Sure. I've always been fascinated with the area of prosthetics and amputation rehab. And I've been in practice for over 30 years now and a faculty member for heading towards 30 years. And during that time, I've taught prosthetics and orthotics, as well as work in orthopedic clinical practice. So those things really inform who I am professionally and the research that I do.
That's pretty awesome. I think 30 years in the field is a pretty impressive feat. And I'm sure in that time you've done a lot of amazing research. With that being said, what's been the most effective way of measuring a patient's balance that you've seen in your research?
I think I started getting interested in this area because I saw a lot of research that looked at the activity balance confidence scale as a measure of balance confidence and how that related to falls in the population of people with amputation. And I started thinking like, just because I'm confident doesn't mean that I would necessarily be capable. And when I started doing research for myself and using the ABC, or the Activities Balance Confidence Scale, I started noticing that some of the people that were responding also did not match up with what their capabilities were. I tell the story often of this one guy who really hadn't used his prosthesis in months and was sitting in a wheelchair outside of the prosthetics office, was there, and I was giving him the Activities Balance Confidence Scale. And one of the questions is, how confident do you feel to stand on a chair and fix a light bulb? And he said, I'm 100% confident. And I was like, really? Because there was just no chance that he could do that. And said, yes, I'm 100% confident. So that started making me think we really should be measuring actual balance ability, not just relying on people's confidence. So I think that's how I got started. The first step when you want to do research is you have to have a valid and reliable scale or measurement. And I was surprised that there was no validated, reliable assessment of balance for people with limb loss, since clearly without a leg, maybe without two, you're going to have balance impairments. So the first step was to determine how to do that, and we did that, published in 2013, by validating the Berg Balance Scale for people with limb loss. I think that was the beginning.
Gotcha. And so you found effective ways of measuring a patient's balance through those means. What are some of the limitations of studying fall risks with your patients?
So first, like the Berg Balance Scale is complicated. It's 14 tasks, but it gives you a pretty good measure across many different populations of a person's balance ability. And some of those things are related to prosthetics. For instance, the most three difficult tasks are standing in tandem, that's like one foot in front of the other. And so that's a difficult task. For a person wearing a prosthesis, they don't have plantar flexion and dorsiflexion without having the movement of walking occurring. And so it's really hard to stand in that way. Also, like turning in a circle, hard to do because prostheses don't really provide a lot of rotation. And also stepping, which onto a step, which involves knee flexion, and that can be challenging, particularly for people with the transfemoral prosthesis. Those kinds of tasks were identified with the Berg balance scale as things that might be related to falls. But yes, like you said, trying to compare the balance with research related to falls and injury is complicated because what do you call a fall? Is it like one fall? Was that such a big deal? Like I fell last year. So we sometimes think of it as recurrent falls or repeated falls. Like if you fall multiple times, that seems like a more significant problem. But then you can think, if you fall and don't get injured, does that really matter? Like maybe I'm just playing soccer, So then you can have injurious falls. Out of the gate, some of the difficulty is defining terms.
Yeah, that's great. Speaking of falls, if a person had poor balance, many would assume that they would fall more, right? What have you found, obviously, in your research with this different scale?
I definitely assumed going into it that poor balance would lead to more falls. But what we found was actually good balance led to more falls, which was kind of a paradox for it. It didn't seem to make sense. So we repeated the study. We did it two ways. We did one small study of 50 subjects and one larger study with over 300 subjects. And we looked at one looking backwards or retrospectively. And we did one prospectively, like starting with the measurement and then waiting to see if anyone had a fall. In both ways, we found that people with better balance had more falls. And I think our interpretation is if you have better balance, then you're more willing and capable of doing more things. So you might go and try to play tennis, and maybe I'll go for that hike through the park. So we found that people were falling more often, which is quite a paradox, which we eventually resolved.
And what did you find to the resolution of that?
So what we did eventually is we started realizing that if you account for the exposure to a fall, that would make a difference. In sports research, it's not enough just to count how many injuries occur in a team over a season or even during a game, because each athlete has a lot of different practices. And so like nowadays in sports research, they track every practice, every training session, and the games. And so we thought the same kind of concept would be appropriate for people with limb loss. So we measured the physical activity as like a proxy for exposure, and we use step counting as a method because there's so many different ways to count steps nowadays. And so what we found, when you account for exposure and physical activity, then it turns out that the people who have lower functional levels are more at risk to fall, maybe 6 times greater risk to fall, and over 8 times greater risk to get injured.
Just out of curiosity, do you find that, the more active, more confident amputee, there's a correlation between, falling more despite having better balance?
Yeah, for sure. I think that is the resolution of the paradox, is that people who are more capable, have better balance, are more confident, and they go do things more, and then they fall in the course of life, just like I fell last year. It's an interesting note, though, because one thing that we did find is if you had high confidence but low balance ability, that was a bad combination, and that would lead to like 4 times the greater risk. So, you have to like know yourself. What are your capabilities, and therefore understand what your risk is. That's an argument for reliable and valid measurements of balance.
And have you found that people learn from their falls and maybe fall more appropriately to avoid an injury? And I only bring it up because, being out there in the field, we'll have people trial things and they're doing amazing athletic moves. And when they fall, they kind of innately know, well, hey, if I fall, I better go this way or that way to prevent an injury.
So, what's important to note is not all falls occur during walking or running, and not all injuries occur due to falls. So I think in the more capable population, as you're describing, that is definitely true. You fall while you're doing some activity, you learn from that, learn to fall a better way, learn to avoid that behavior, like, walking backwards, for instance. And then you might reduce your falls. But what we found in our sample was like one person in particular, she fell 3 times, not once, not twice, but 3 times doing the same thing, which was getting out of bed, forgetting that she didn't have a leg, and then just falling. So, we try to account for things like that, like use a night light, which is somewhat annoying to sleep with, although you can get one that's motion sensitive, so that when you get out of bed, maybe that little bit of light will help remind you, like, oh, take care, I don't have a leg on one side or the other.
And how about advancements over time? I mean, I know clinical care has increased a ton over the past 20 to 30 years, and same with the advancements in the technology of the prosthetics. What does the timeline look like for maybe just a metric of number of falls per patient and or confidence levels increasing over time and allowing for more activity?
In general, like the rate of falls, just as a raw number, is like 50% of people fall in a given year. But by looking at our step counting activity, it actually boils down to about 1 fall per year of step counts for an average person. However, some people are not actually doing the average step counts. Like many people, particularly those with a transfemoral amputation or bilateral amputations, they walk a lot fewer steps than another person. Something to aim for, like 10,000 for a person with 2 legs, is about equivalent energy expense-wise as 8,000 steps for a person with a transtibial amputation, or about 7,000 steps for a person with a transfemoral amputation.
Yeah, I've never heard those numbers before. That's great to know.
Yeah, that's in a scoping review that we published, I think, in 2021. Just a side note, but the overall risk is maybe like 1 per average step walking, year. That's an average of maybe 2,800 steps per day, which is more than many people are walking. But in terms of the technology, yeah, I'm super excited that Medicare has changed the policy and allowed at least some people who are at the K2 level to get microprocessor knees. I think that's really exciting. And always from myself, like those are the people that were most at risk to fall in my mind. So I'm excited about that. That doesn't mean that everybody needs a microprocessor leg. Not everybody is going to use that or need that. But it's good that it's available for those that might.
Yeah, and you mentioned a lot of falls happen outside of walking or running. I remember people telling me that sometimes the hardest thing is just going from a stand to sit, and somebody, say at church, you're standing and sitting multiple times. Do you guys figure out activities and what leads to the falls like that are non-activity driven?
Yeah, it's tough. I mean, we had one subject who was pretty high performing. He got injured scraping his leg getting out of the swimming pool. But you know what I say? More power to you. Go to the swimming pool. You should do those things. We all can have, minor injuries. A person with lung loss is just a person. And so like the rest of us, small things can happen. I like to make people not afraid of some of those issues. But I'm glad you mentioned sit to stand, because some of the things that I recommend for people just in terms of strengthening, like if there was only one strengthening exercise, period, of all exercises, I'd have people do squatting to a chair. People do that already, have difficulty already doing it. And I think the way to get the most out of that activity is just to what I call squat and hover. You squat down, but just hover over your chair as low as you can go. Even 6 seconds is enough to increase the strength, but also change the actual tendon tissues. Doing that can help with the problems that people have, just getting up, getting down, going up and down a stair. And then the CDC published age-matched normals for performance for sit to stand and how many you can do in 30 seconds. I think at 62, the standard would be to be able to do 14 or 15. So, and that's easily accessed on the internet. So it gives people like a gauge of like, how do I stand compared to my age-matched peers?
That's awesome. And the one mechanical feature that I always am marveled at is hydraulic resistance in a transfemoral prosthesis. Do you guys measure things like, what type of value hydraulic resistance as you go from stand to sit improves, I guess, the success rate of falling less?
There is, as far as I know, no such research, although it's an interesting question that you're asking. The suggestion that people do squats, I would make that same suggestion for all people. I always tell my patients, do you want to get off the toilet by yourself when you're 80? And the answer is always yes. Nobody wants to require help to get up from the toilet. But that has no actual research to back that up. It's just common sense. My clinical experience over just such a long time has shown me like, yeah, you definitely want to be able to do that.
So what are some of the rehab practices that you do? I mean, you mentioned how patients can, do that squat or hover. Are there other things that clinicians out there could be doing to improve balance, or just mention to their patients that, hey, this could help you out?
Being able to find things that are basic but also safe are really important. So earlier I mentioned that on the Berg balance scale, the most difficult task for the person with limb loss to perform is to standing one foot in front of the other and balancing. To do that and hold it for 30 seconds is a really, really good exercise and task. A person might start off not even able to do it for 3 seconds, but eventually they could build up to 30 seconds. And someone who is really good at it, you could do it for 30 seconds while like maybe turning your head, which is really, really challenging even for a person who does not have limb loss. I will say though, since there's the risk of falling while you're balancing like that, the way to make that safe is to stand in the doorway while you're doing it, because you can only fall left or right. And so if you start to fall, you'll just be right there at the doorway and you'll be able to catch your balance easily.
The doorway is kind of like parallel bars in that situation.
It really is.
Do you find CPOs providing tips like that out in the field? I guess in your experience, and I don't know if you go to fittings or not, or if they sometimes bring you in for preliminary, activity advice.
I've been to many a prosthetic fitting, a lot of C-leg or microprocessor setups. My observation is your typical prosthetist is pretty time challenged. They've got a lot of things that they need to get done in a relatively short period of time. So they don't really have a lot of time to give training suggestions, not too much, unless it's really going to be a checkout and you're really, getting them ready to go. I think that's why I like the squat and hover with tandem standing in the doorway. Those are simple tasks. The squat hover, you already do that. Just doing that, but holding it is a small adaptation to what is already, common practice while you're determining, how much resistance for the knee, etc. It's an easy solution. When I find myself doing that more often is in the sessions with the physician when they're trying to determine K level, or after they've got their prosthetic leg and they're getting a checkup. I find that's a useful time for the PM&R doc because the patient may or may not get physical therapy.
That was going to be another question. How often does it occur that you get a full script for rehab on top of the script for new prosthesis?
I think in general, if it's a new prosthesis, the person is going to get physical therapy. However, there are not that many people with amputations, not that many. And so of the people who are physical therapists, not that many have experience working with a person with a prosthesis. So sometimes what I hear just in and around and out in the community is that people who go for amputation training are not always happy with what they ended up receiving. And that makes me sad because, that's why I'm in physical therapy education. I would improve the system from the inside. One of the things we did, in fact, was to produce the first educational guidelines for physical therapists all through the states so that educational programs can have a sense of, this is what you should be teaching. So I hope that improves as we go along. But you struck on a soapbox topic for me.
That means it was a good question. Okay.
That's a good question. Because in outpatient physical therapy practice, we get all sorts of people for low back pain who might get 12 or 24 sessions of care, or knee pain or knee arthritis or hip arthritis. They might be there for 8, 12, 16 sessions. And I always think, heck, my person with the prosthesis, they also have back pain. They got knee arthritis and they got hip arthritis. Why aren't they getting to go to physical therapy? We get people for balance training. They're really just an older person with some degraded balance. How come our people with the limb loss are not getting the prescriptions just for balance training? So I really encourage and advocate for patients to tell their docs, I need to have physical therapy for my back pain. The fact that I have a prosthetic leg is not necessarily the one and only thing. That does not define a person, because on top of that, they have all these other problems. And so I really hope in that way to get people referred to physical therapy more for the basic things that happen: back pain, knee pain, hip pain, poor balance. And in that setting, then the person with the prosthesis can also get care that it would need that will improve their life in a variety of different ways.
Dr. Wong, what are some tips clinicians and instructions that they can give their patients to help them gain activity levels and avoid falls?
Yeah, I mean, the number one recommendation actually in the clinical practice guideline is connecting people with support and support groups. And so there's a lot of different wellness groups that are listed on the Amputee Coalition of America website. I like to call my friends Todd Schaffhauser and Dennis Older, who organized the Amputee Walking School here in New York, but although they travel around the country. And it's just a good way to improve your physical activity and just do more, which will have a benefit in a variety of ways for every person's body.
And Dr. Wong, I know that you said you're also a great resource and you're available if anybody wants to reach out, right?
Yeah, for sure. You can reach me on the Columbia Physical Therapy Program website. My email is attached to that, so you can certainly reach out. Other people do. Also, you can find me on LinkedIn. I'm happy to connect people when I can to other providers or groups that they might be interested in.
Wonderful. Well, thank you so much. I really appreciate you taking time out of your busy day to spend it with Travis and I and all of our listeners. But yeah, just can't thank you enough.
Yeah, appreciate you being here.
Travis, Brendan, thank you for having me on. I really appreciate it.
Thank you, Dr. Wong.
To learn more about Dr. Wong's work at Columbia University or to connect with him on LinkedIn, follow the links in our show notes.
Thank you for listening to the O&P Check-in, an SPS podcast. We hope you enjoyed the episode, and if you did, be sure to leave a review and subscribe to the show on Spotify, Apple Podcast, or wherever you listen to your podcasts. Have a question or topic suggestion? Email us at spspodcast@spsco.com. See you next time.